Good afternoon. I am Dr. Tanya Smith-Bryce. I am Vice President of Education at the Council on Social Work Education and am chair of this work session and of the planning group for today's workshop. So good afternoon and welcome. Today's session is entitled Exploring a Culture of Fairness, Respect, and Anti-Racism in Health Professions Education, Influencing Institutional Structures. The purpose of this workshop session is to explore actions and perspectives from funders on dismantling institutional structures that perpetuate discriminatory treatments, unfair policies, or biased practices based on race, and to consider some metrics for measuring anti-racism structures of institutions. Thanks to the generous funding from the Josiah Macy Jr. Foundation, a group of scholars from around the country were invited to take on the enormous task of strategizing ways in which we might be able to eliminate racism, and specifically anti-Black racism in health professions education. We began meeting late summer of 2021, and we determined that there are several levers of change in this area. The first lever is preparing a culture of change, one in which an anti-racist culture can be nurtured. Another lever of change is with accreditors of health professions education programs. And yet another lever was with deans and other academic administrators. We identified funders as a lever of change. And we also recognize that we must measure this change, so metrics are another important factor of this change. We have conducted workshops on each of these areas and are excited about today's workshop with a focus on funders and on metrics. So I'm excited to introduce to you my co-chair of this work group, Dr. Richard Baker of Wayne State University School of Medicine. And he will provide some framing remarks for today's workshop. Rick?
Thank you, Dr. Bryce. Given the broad scope of this challenging topic and the fact that our audience is at different levels of knowledge and understanding, I'd like to present 5 foundational points. These points are admittedly aspirational, but hopefully will be useful in facilitating a common understanding of the topic at hand and also a more focused and intentional discussion. First, I'd like to make a clear distinction between DEI and anti-racism. DEI is extremely important, but the focus of our planning committee and its activities is anti-racism. DEI enhancement may be a pathway to or platform for anti-racism. However, progress related to DEI should not be substituted or conflated with the achievement of goals related to anti-racism. Secondly, I want to point out that race is not a biological construct. It is a social construct. Race as a biological construct is a pervasive and strongly held but inaccurate belief and assumption. Science has definitively demonstrated that race is not based upon meaningful biology. It is at best a poor and often misleading proxy for real biological determinants such as ancestry or genetic predisposition. This misrepresentation, particularly among our faculty and students, is highly problematic and is the basis for perpetuating false beliefs, misinformation, inappropriate curriculum, and inappropriate care. As my third foundational point, it should be emphasized that health inequities experienced by specific race ethnicity groups are primarily the product and consequences of racism and not race. Racism is a powerful social determinant of health. Despite the undeniably powerful impact of racism, historically the term racism has been typically de-emphasized, ignored, or actively avoided in discussions related to health. My fourth foundational point is that it's useful to distinguish between structural or institutional racism versus interpersonal racism. Discussions, activities, and proposed interventions germane to anti-racism efforts in the health education environment primarily focuses on structural and institutional racism, as opposed to interpersonal racism that functions at the level of the individual. As articulated by authors in some of the pre-readings provided, structural racism is a direct derivative of the institution of slavery. It is defined as, quote, the totality of ways in which societies foster racial discrimination through mutually enforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice, unquote. This includes the processes of racism that are embedded in laws, local, state, and federal, embedded in policies, and embedded in practices of society and its institutions that provides advantages to groups deemed as superior while differentially disadvantaging racial groups viewed as inferior. My fifth and final point sets the stage for the ensuing discussions. We know that structural racism is deeply embedded in all of our society and that it broadly involves numerous actors across multiple institutional platforms. Given the reality that structural racism extends far beyond the educational environment, today's overarching questions are twofold. First, what is the role and the challenges of funders and organizational leaders in creating anti-racist organizations in the HPE arena? Secondly, what is the role and challenges of funders and organizational leaders in mitigating structural racism's pervasive and damaging effects on our students, on faculty, and the patients we serve? Hopefully, this preamble has given you somewhat of a common understanding and awareness. At this point, I have the pleasure of handing over the program to two of my planning committee colleagues, Dr. Lemietta McNeely, Chief Staff Officer of the American Speech and Language and Hearing Association, and Marcus Henderson, a board member of American Nurses Association and PhD candidate at Johns Hopkins School of Nursing. I hand over the program.
Thank you, Rick. It's a pleasure to have this particular panel be able to come together today and share some significant information with us regarding taking racism out of institutional structures. And I will introduce each of the panelists and also encourage you to look at their full bios, which are in the materials that you have. And as we also move through this conversation and discussion, we encourage you to use the Q&A, and Marcus is going to be monitoring the chat so that we will be able to address questions that you have. Each speaker will have 5 to 7 minutes to talk about their topics. Marcus, do you have anything to add?
Not at this time, and looking forward to the panel.
Great. So we have 3 wonderful panelists that will share information with us today, and I'd like to introduce them. Sheldon Oliver Watts is the program officer with the Robert Wood Johnson Foundation. Looking forward to hearing from you today, Sheldon. Sandra Gasca Gonzalez is the vice president of the Annie E. Casey Foundation's Center for Systems Innovation, and we look forward to hearing from you, Sandra. And Holly J. Humphrey is the president of the Josiah Macy Jr. Foundation. And Holly, we look forward to hearing from you. Thank you. Sheldon, would you like to begin?
Sure, I'll go ahead and get started. Good afternoon again, and thank you. I'm delighted to have this opportunity to share information about how the Robert Wood Johnson Foundation is working towards dismantling structural racism in the academic health setting. I'm joining you all today from Philadelphia, Pennsylvania, home of the ancestral lands of the Lenape, indigenous people of the northeastern woodlands. So one of the foundation's guiding principles is that we seek bold and lasting change rooted in the best available evidence, analysis, and science, openly debated. Research has consistently demonstrated that individual and structural racism spanning generations denies opportunities to people of color and robs them of their physical and mental health. Consequently, understanding and addressing the impact of structural racism on health is essential to the foundation's goal of building health equity, hence providing everyone in America a fair and just opportunity for health and well-being. So how has the foundation worked to address structural racism through its grant making? There are several legacy pipeline approaches that have continuously supported underrepresented groups in academic health. So for over 40 years, the Harold Amos Medical Faculty Development Program has supported medical faculty from historically disadvantaged and underrepresented backgrounds to become leaders in the field of academic medicine and science. The program was created to increase the number of underrepresented faculty who can achieve senior rank in academic medicine, dentistry, or nursing, and who would encourage and foster the development of succeeding classes of health professionals. 4-year postdoctoral research awards are offered to health professionals who are committed to developing careers in academic medicine and serving as role models for students and faculty of similar background. Another legacy program has been around since 30 years, and that's the Summer Health Professions Education Program, which has supported college students interested in the health professions through a free summer enrichment program. SHPEP, as we call it, focuses on strengthening the academic proficiency and career development of students underrepresented in the health professions and helps them prepare a successful application and matriculation into health professional schools. But more recently, we launched 2 initiatives focused on removing barriers to health equity and health equity research. These initiatives challenge the default research environment inside and outside of the academy by supporting the scholarship and professional growth of researchers from underrepresented backgrounds, addressing structural racism in the field of research, and fostering a learning community that can advance the scope and impact of research to identify and address the root causes of health, recognizing that they are strongly linked with structural and systemic racism. One of which is the Health Equity Scholars for Action Initiative. And this is a new program that supports the early career development and academic advancement of historically underrepresented health equity focused researchers. Awards were made to early career scholars to address the challenges that many underrepresented researchers experience in the academic environment and help them overcome obstacles to earning tenure. Grants support 3 aspects of career development. The program offers research funding, provides mentorship, technical assistance, and other capacity building services, and connects researchers to a community of support through activities organized by the foundation and through its signature research programs. Another initiative, Transforming Academia for Equity, was designed alongside the Health Equity Scholars for Action, noting that these researchers don't work and develop their careers in a bubble. So we really had to think about the context and conditions where they're doing their work. We're collaboratively supporting diverse institutional teams from schools and programs of public health as they embark in a process of introspection, deep reflection, and development of organizational change strategies to make the academic environment more supportive of innovative methods in health equity research and of underrepresented scholars. So this is a bold opportunity for academic institutions to identify, confront, and move beyond the shadow of the historical roots of structural racism and exclusion. This work will be done in partnership with the Association of Schools and Programs of Public Health to create inclusive space for all faculty, including those from diverse races, ethnicities, abilities, sexual orientations, and gender identities, and support research topics and approaches that reflect the varied experiences of historically underrepresented faculty and communities. Now, we acknowledge that we are on a learning journey. We don't have all the answers, of course, and these recent activities are an early attempt to develop pathways for addressing structural racism in the academy. Through our evaluation efforts, we hope to document and examine what it takes and whether it is possible to successfully implement these activities, elucidate interconnections and their potential for collective influence, and provide preliminary insight about the influence of the initiatives on this field in creating positive disruption. Thank you.
Thank you. Sandra, we'd like to hear from you now. Thank you, Sheldon, for sharing those important points with us.
Thank you so much. I actually do have a couple of slides that I want to share with everyone. Good afternoon, and thank you for having me here today. Just by way of background, I want to share a little bit about my role at the foundation, which really is to focus on preventing system involvement, as well as helping systems transform, specifically related to child well-being, foster care, older youth transitioning from foster care, and juvenile justice. So I wanted to make sure that was made a little more clearly. But I want to start by saying that as a funder, we really do have the responsibility and the opportunity to set the example and to model the change that we want to see in the world, the change that, you know, we all believe is necessary for children, families, and communities to have equitable access to thrive. So at Casey, much like what Sheldon mentioned, we started this journey by taking a close look internally. We really had to ask ourselves, how do we reflect the communities in which we work, play, and raise our own families? So we went on this journey internally to really determine how we could embed equity into all of our work and make sure that it wasn't just one-off over here on the side. And this is how structural and institutional change happens, by really building it into the fabric. So then we raised the bar by connecting with our grantees to encourage them to do the same self-reflection. So thank you for going to the next slide. Many of our grantees and partners kept asking us how and where do we get started with this work? So we developed an action guide to help them understand what steps to take to ensure that we are all creating equitable opportunities for the populations that we serve. So at a very high level, I will say that the 7 steps to equity for us starts with making sure that we have an understanding of what it means to have race equity and inclusion principles. What does it look like? What do we mean by it? What is our common language, which I believe this webinar series has focused on in the past. We also have a strong focus on engaging affected populations in the solutions of the issues, plus making sure that the data is disaggregated so that we actually know what the issues really are, and we're not just aiming at something that might be too vague. And then simultaneously, we also have to focus on things systematically and look at root causes of inequities so that the strategies can be invested in that will actually tackle the deepest rooted issues. So obviously there is no one magic strategy or approach. If there was, we would have solved this problem centuries ago. Racism, as everyone knows, is systemic, and it will take continuous effort to create policies that really remove those barriers and create opportunities. And what we're really doing is encouraging our grantees to keep working, testing, implementing, evaluating, and sharing their progress with the field. So if you could go to the next slide, please. To help keep our eyes on the ball internally, we began collecting and measuring grantee data. And this was about 7 years ago when we started this. And in particular, we asked ourselves, how well did our grantees' leadership team, staff, and boards reflect the demographics of their communities and those that they serve? And with this data, we can engage in meaningful conversations with them about how to better serve through better representation. And what we have seen in the recent years in our work at Casey and with our grantees is a trend toward a more focused effort to have more people of color in the position to help lead and maintain the work. On this particular slide here, you can see that there's an upward trend of our investment and or growth of organizations since 2018 to reflect CEOs, and 50% or more of staff are people of color. So 27% in 2018 to 35% in 2020. If we go to the next slide, correspondingly, our funding shifted to more organizations of color from 17% in 2018 to 23% in 2020. If we go to the next slide, this slide here really shows that we began looking at what racial equity and inequity looks like programmatically. So for instance, we know that too often poverty, unfortunately and inaccurately, becomes a proxy for neglect. With nearly 73% of children in poverty being kids of color, we see an extraordinary over-surveillance of families of color in our child welfare and juvenile justice systems. And by the time kids in the United States reach adulthood, 37% have crossed paths with Child Protective Services as a potential victim of maltreatment, according to the American Journal of Public Health. And this rate is highest at 53% for Black children. Let that sink in. 53% for Black children would have had a child abuse neglect investigation in this country. And it's 32% for Hispanic children, 28% for white children, 23% for Native American, and 10% for Asian and Pacific Islanders. So the point here really is that the prevention space for child welfare has to be a big investment area for us. And we've pivoted to that because our goal is to have impact at this population level. So all of our funding, technical assistance, and capacity building in this area is really working towards reducing the number of Black and Brown children entering the system. And we're doing that by investing in communities and system leaders working together to co-design a new way for families, with families being a part of the solution, to thrive on their terms. So this is just one example of how we've put our equity principles into practice. And I'll just wrap up my initial remarks by saying that this work has to be intentional and evolutionary, and we have to get out of our own way as philanthropy sometimes. Our approach wasn't a do it our way or lose our funding proposition. We truly wanted to and aim to inspire others and continually challenge ourselves to do all of our work with an eye toward equity and inclusion. So that's just a sample of what I wanted to share. And I think I'll hand it over to Holly or Lemmy.
Great. Thank you for sharing those statistics with us. Some of them are quite disheartening. Others show some growth and improvement. Holly, would you please share information with us from the Macy Foundation?
Thank you very, very much. And let me begin by thanking all of you who have been working on this workshop series. You are doing very, very important work. You've done a big heavy lift, and I want you to know that my colleagues and I at the Macy Foundation are very grateful. If you don't know, the Macy Foundation also has a very long history of advancing minoritized and marginalized, underrepresented communities, really going back to the founding of the foundation almost 100 years ago. The founder of the Macy Foundation, Kate Macy Ladd, was a Quaker, and that Quaker upbringing likely influenced her attention to marginalized communities. Over the course of the history of the Macy Foundation was one of the founding funders for the Morehouse School of Medicine and for the National Medical Fellowships. The Macy Foundation has sponsored a number of very important reports related to the lack of diversity in health professions education. And in fact, one of those reports ended up being part of the oral arguments before the Supreme Court. So that's just a sense to give you a perspective that the Macy Foundation has had a very long history of being interested in this work. And I was interested to hear Dr. Watts mention Dr. Harold Amos, who was actually a board member of the Macy Foundation for many years. And for those of you who may not know, Dr. Amos was the very first African-American to become chair of a department at Harvard Medical School. And as I said, he was a member of the board of directors of the Macy Foundation. And the commitment from our board of directors going back decades has been steady and focused on issues related to minoritized groups. Now, it's also the case that I personally joined the Macy Foundation in July of 2018, having spent 37 years caring for patients on the south side of Chicago. And I had a chance to see up close on a daily basis the ways in which my patients were disadvantaged by the structural limitations to everything in their life, including health and healthcare, education, access to food. And those structural determinants determined, as all of you know, their health and their life. What is most alarming is that the Inglewood neighborhood on the south side of Chicago, where a good number of my patients came from, today in 2021 actually has a life expectancy of 60 years. 20 minutes north of the Inglewood neighborhood on the lakefront in what we term as the Gold Coast of Chicago, the life expectancy is 90 years. That gap in life expectancy is the largest of any radius in the entire country. And so it was that background that I brought with me to the Macy Foundation, such that when I arrived, the board of directors engaged in a strategic planning process. And by October of 2019, the board of the Macy Foundation endorsed a strategic plan that has a focus on the clinical learning environment. And the ways in which we chose to focus on the clinical learning environment is aligned with and consistent with our mission. Our mission of improving the health of the public means improving the education of health professionals. And to do that, we have 3 funding priority areas: equity, diversity, and belonging in the clinical learning environment, collaborative high-performing teams in the clinical learning environment, and navigating the ethical dilemmas in the clinical learning environment. And as you, I hope, can see, all 3 of those funding priority areas have a direct link to anti-racism. Now, there is a lot I could say, and we will have time over the course of the afternoon today to talk about some very specific efforts related to anti-racism. Some of the very specific things that we look for as a funder are projects that are action-oriented. And we're looking for action-oriented projects because of this long history of trying to move the needle. And in fact, we have the kind of disparities and structural limitations, some of which you've heard mentioned today, and I have specifically called out my personal experience. So in looking for action-oriented projects, we are looking for programs in health professions education that have projects that can be easily disseminated among multiple institutions. And we're also eager to support coalitions and collaboratives of projects. So for example, a year ago, we considered a proposal from the Icahn School of Medicine at Mount Sinai. And that proposal was to undergo an anti-racist transformation of their entire institution. We invited that group to consider forming a coalition with other medical schools so that we could catalyze more active spread of their ideas. And they were up for the challenge, agreed to move forward, and issued a call to all medical schools in the country to apply to be part of their coalition. They had 42 schools apply. Ultimately, in order to launch the effort, they were able to choose 11 to work directly with them on this anti-racist transformation. And we at the Macy Foundation are hoping that that project and those original 12 schools are going to catalyze an effort that can be spread across the country. So that's just one example of the kinds of projects that we as a funder are looking to catalyze and disseminate so that we do not have to wait another several decades to see the kind of change that we are so urgently in need of. Let me conclude by telling you that one of the individuals who grew up on the south side of Chicago, who I did not know personally, but I certainly knew the story. And that individual is a young man who was buried at age 14 by the name of Emmett Till. Emmett Till was buried at age 14 after having been lynched in Mississippi in 1955. And I don't know if you know, but the United States Congress has just passed anti-lynching legislation. It took 100 years and 200 attempts to get through Congress for that legislation to pass. And when did it pass? 15 days ago. So the urgency to create health for our communities has never been greater. And we have a lot of work to do. And it's for that I am so grateful to all of you for being engaged in this very important work. And I'm going to stop there and really look forward to the questions and your comments that I'm eager to learn from. Thank you.
Thank you to each of you for the information that you've shared with us. We clearly have made some gains, but there's a lot more work to be done indeed. So I'll start with this question. And Holly, you gave us an example of one of those reactions from your grantees. But as you've implemented, and any of you can address this question, as you've implemented requirements or strong suggestions regarding anti-racism and DEI, what have been the reactions of your grantees?
I think I can share as it relates to one of the initiatives that I mentioned, Transforming Academia for Equity. That initiative is focused specifically on addressing many of the kind of historical roots of racism and how it has kind of infiltrated the academy in many different ways. We are taking a learning stance as we move through an effort to get institutions to really reflect on the impact of structural racism and how they can begin to intentionally make change that would benefit both the faculty and members of their institutions immediately and to come. And with that, we intentionally focused on schools and programs of public health. We thought that they would be a good exemplar, primarily because we could partner with the Association of Schools and Programs of Public Health to really elevate and disseminate what we learn and the types of shifts that occur in the context of our vision for that initiative. When we did our initial informational webinar about that activity, we had well over 200 individuals who signed up for that webinar. I think there's about 180 schools and programs of public health. So we probably had a larger berth in terms of those who are interested. But additionally, we had a number of applications of interest, letters of interest, letters of intent rather, for that particular initiative. Because it is in its very first stage, its very first iteration, and we hope to continue to welcome other institutions to go through this process with us. We couldn't entertain all of the applications, but certainly I think there's a appetite that's ripe for this type of work. I think part of it is understanding the scope of what is possible within the context of where you can learn and how you can learn, and then how we can use that to scale many of these ideas and certainly what we've learned from these opportunities. And we hope to do that in the context of this initiative, primarily because we're focusing on schools and programs of public health through working with institutional teams, but those institutional teams are made up of leadership and representation from all across the university. So as much as we would like to see the impact of those efforts within schools and programs of public health, we are hopeful and encouraged that these opportunities will ladder up and have a broader impact at the institutions who are participating.
One of the efforts that we've been involved with is known as Thriving Families, Safer Children. And it's really a partnership between the United States Children's Bureau, Prevent Child Abuse America, our cousin foundation, Casey Family Programs, and ourselves. And we're really what it is a movement to build a child and family well-being system designed by those affected by child welfare to prevent system involvement. And it actually requires the Child Protective Services Agency leaders and community members, young people who have experienced the system, to actually be involved and really figure out how to prevent the need for a formal system. So it's really getting clear on what's needed in the community to prevent that from happening. And race equity is at the center of all of this, along with socioeconomic status, and really dealing with who are the most marginalized people in the community. And we started with 4 locations. We started with South Carolina, Nebraska, Colorado, and Los Angeles County. Very different locales. And we saw a lot of different issues. Primarily the issue really is, and I should say now we're at 22 states that are involved in this effort in an 18-month time span. So there's clearly energy around people wanting to work on prevention. The issues there primarily have been around sharing power with each other. So, you know, we have these system leaders who, by virtue of their mandate, which is child safety, and they have, you know, millions of dollars that they invest in a system that is reliant on kids being in the system, trying to get them to think differently and to share the authority with community members to actually create something different has been one of the challenges. Community members and young people being able to articulate in a language that system leaders can understand to get to a strategy that they all agree on has also been a challenge. And our role really has been to invest in how do we help them be able to come together to figure out how to work through some of those challenges so that there is true, authentic co-creation happening and that we are not the ones prescribing any one method. And I think that that has been, there have been a lot of lessons around language. What does it mean? What are you talking about when you say you need services or you don't want services? So there's been a whole host of issues, but I would say the opportunity really has been just even getting them together, and they're coming up with plans on and actions, real actions around. An example is addressing the neglect statutes in their locations that often ends up with a lot of families getting involved with child welfare that don't need to be involved in child welfare. So that's just one example of what we've seen.
Thank you for sharing some of the challenges. Holly and Sheldon, are there any other challenges that come top to mind for you that you'd like to share with the group?
I'll mention one thing, and that is, as you heard from my comments, the Macy Foundation has a long history of being committed to these very important efforts, and that's certainly a part of our strategic plan. But one of the things that we did, actually precipitated by the murder of George Floyd, is we restated our commitments to anti-Black racism in particular. And when I made a public statement about our commitments, I made a commitment to not only stay aligned with our priorities, but to take a look internally at the way that we did our work. And as much as we as a foundation have been aligned and committed for decades, there are important things you learn when you look inward. And we learned, for example, that the invitations we extend to our conferences, the invitations to write commissioned papers, the invitations to be a guest author for one of our blogs, and so on, and the grants that we award. When we started looking at our internal data, broken down by race, ethnicity, and gender, we have a lot of work to do internally. And so it is an important part of, I think, the overall process for an anti-racist transformation to not just think the problem is outside of us, but there are things we continue to learn inside as well. So that was, I think, an unexpected but really important challenge.
And I just wanted to echo Holly's perspective on, this process. It is a process. I mean, the Robert Wood Johnson Foundation is, I think, the largest healthcare foundation in the United States, and taking a stance on, dismantling structural racism because it is core to our interest in addressing health equity, I think is a process. It's a learning process, and we want to approach this in an intentional manner. And I think that, that process of learning internally, thinking about the strategies and the things that we have in place, whether or not they serve, really focusing on structural racism, I think is an important area to highlight, primarily because it is a process, and it is a process where we both look internally, look at what we're doing, understand, where there's overlap, and how to, use our resources to address a problem that's been around for such a long time. And the Robert Wood Johnson Foundation is not going to address structural racism by ourselves, but certainly understanding the role that our partners, other foundations, other agencies and organizations play in that process as well.
Great. So you've each talked a bit about some of your internal and your external processes for review. Do you, or how have you held your grantees accountable in the area of DEI and anti-racism?
I can jump in here and just probably say something unpopular. But one of the things that we do expect is results, and that they are measurable in some way. And I know that the next panel will talk about this, but we want to know, even, how much did you do? How well did you do it? Is anyone better off? You can define that, but we're not a foundation that puts money out the door for general reasons. We have clear population level results that we are aiming for, such as the elimination of youth prisons, reduction in youth involved in probation and child welfare. All of those require some level of analysis and strategy implementation. And some, I think the criticism we get is that we might be too prescriptive, and in some cases we are. It's aimed at trying to get at a balance, because we really want to make sure that the investment we're making is having some traction. And I would just say that we have asked people to share, even just beyond the performance data related to the grant, just some of the things that I mentioned in the data that I shared, like what is the makeup of your organization? What is the makeup of your board? And I didn't say this earlier, but we hold ourselves accountable to that as well. We can tell you 65% of our population is diverse. Our leadership team is 90% diverse. So, there are things that we ask of others, but we're also holding ourselves accountable to. So those are just some examples of what we're doing.
Great. So Marcus, I'll go to you and ask if there are any questions that were in the chat. But I also, while you're pulling those, or a question, after our accreditors session, which happened in early February, a number of the accreditors who were also presenters got together to continue the conversation, learning from each other and supporting each other. Might there be a similar opportunity with funding organizations who are committed to similar goals and to continue a conversation?
I think so. I think the space is ripe for opportunities for collaboration, for cross-fertilization, for ways in which we could continue to think about dismantling structural racism and learning from one another. So I think it's just the proper venue and ways in which we can support those conversations and those relationships and those partnerships moving forward.
Yeah, I agree with that. And one of the things that we are doing that has not been in place historically is we are adding a section to the grant applications that invite the potential grantee to comment specifically how their project aligns not only with our priorities, but how it will impact the clinical learning environment in their institution related to anti-racism. And I regularly receive inquiries from other foundations to try to share, best practices for how we are holding grantees accountable. But as I said, we are early in that process and are adjusting our application in the way that I just mentioned.
I would just echo that and just say there are actually some people already meeting in the juvenile justice space, in child welfare, in housing, some collaboratives already focusing on this topic. So there's definitely, this is the moment.
Great. Thank you, Sandra. Marcus, are there any questions to share from the chat or the Q&A?
There's one question that just came through that I'll share with the group, and then I do have some other questions if we have time. But the one question from one of our attendees is, as a member of the so-called BIPOC community, I often find some intangible inequities in systemic norms and assumptions, especially about the minority beliefs of care and wellness. How do we address some of this embedded bias? And I wonder if Dr. Humphreys might start, because it seems like a clinical learning environment type of question of how do we challenge these biases that a lot of providers still hold about minoritized groups?
Yes, that is a great question and a big challenge. So thank you for raising the question. In February of 2020, the Macy Foundation convened a conference that addressed that topic directly. That conference was organized around the theme addressing harmful bias and eliminating discrimination from clinical learning environments. We brought together 44 leaders of schools of medicine, nursing. We also had students and graduate students among us. And that group that was convened came up with a series of recommendations and action steps to try to impact the learning environment to do what the title of the conference said, which is to really eliminate discrimination and address the harmful bias that is pervasive. And so I invite you to go to our website. That report is on our website in its entirety. You can download it. And the point that I want to emphasize is I know that many of you participating in these workshops have thought about and often worked on building the pipeline of young people into our health professions schools. And by the Macy Foundation focusing on the clinical learning environment, we are making a statement that as a nation, we need to not only focus on holistic admissions into our health profession schools, but the holistic process of becoming a health professional. Because to have an admissions process that's completely disconnected and out of sync with the learning environments actually creates more trauma. And, retention rates become a real problem. And we don't ultimately graduate the kind of diverse health professions workforce that our country so desperately needs. So this question just provoked that reminder that the harmful bias is all around us, and the groups who I am personally most eager to protect are the vulnerabilities of our patients and the vulnerabilities of our learners in those environments. So I again recommend the report to you, and it's a big question and a big topic, and I hope the report might be helpful.
Well, thank you to each of you for the wonderful information you've shared with us this afternoon. We have a little less than a minute left for this particular panel. Does anyone have a comment that you'd like to make to close out? I think you've given us some excellent data, some information, some challenges, some opportunities, some information around what you've been doing and what you plan to do moving forward, and how you're holding grantees accountable. So thank you for sharing that today.
Thank you.
Thank you. And I just wanted to echo the sentiments of my, fellow panelists that, we're all early in this journey. There is so much to learn in terms of how you actually address structural racism, address the systemic racism that we know is so problematic. So it's a process. And as we learn, it's very important to share and to lend and to give back to those communities that will be able to really embrace and implement some of those lessons.
Great. Thank you, Sheldon. And Rick, I'll pass the mic back to you.
Thank you very much. Again, great discussion. Hopefully you panelists will be able to stick around and listen to another really interesting discussion as we go forward. I'm going to hand this off to my colleague, Dr. Luba Konopasek, Senior Associate Dean for Education at the Netter School of Medicine at Quinnipiac University. So my
Thank you
colleague,
so
Luba, take it away.
Thank you so much, Rick. So good afternoon and welcome to our second panel, which focuses on metrics as they relate to anti-racism within institutional structures, and in particularly education for our professions. So I'm delighted that Marcus is again joining as a co-moderator. You heard that he's a first-year PhD student at Johns Hopkins. He was one of the architects of today's workshop panel and a member of the workshop planning committee. Thank you, Marcus. So he'll be moderating the chat again, and we'll be joining in a little bit later. So I'd like to begin by acknowledging that while the panelists for this workshop and for this particular session are from the Houses of Medicine and Law, and I'll introduce them in a moment, our hope for this workshop is really to draw on the wisdom and expertise of the 17 professions represented here and inspire change and work across all of our professions. And so I hope that it's called a workshop, that we're all going to be working and engaging in an active conversation after our panelists speak. And then in kicking things off, a little disclaimer, and I'm going to echo Sheldon, who was in his closing remarks said that we're still early in this journey. And I would just say we are especially early in our journey as we think about defining and collecting metrics around dismantling structural racism in the education in our professions. So as I continue my introduction, Rick had 5 grounding principles. I have 3 pieces to share. And the first one, again, is about the level that we're really, that we're talking about. So Kamara Jones has developed a framework that defines race on 3 levels. And so again, as Rick said, we're really focusing today on the institutionalized level. Personally mediated and internalized levels, other 2 levels that she's defined, are certainly important to address, but our focus today is on the institutionalized and really thinking about our educational systems and the policies and procedures which are part of our entry into and success in education in each of our professions, which may be perpetuating structural racism. And that's something that Holly just talked about, right? Was she talked both about entry and retention of our learners. The second piece that I just want to ground us in is this idea of metrics. And so we were speaking a lot about metrics, And it got to the point where I thought, wait a second, what does the word metrics even mean? So I looked it up. And of course, it really relates to a quantitative measure. And so I wonder, as we think about metrics, is it only the quantitative measures that are important, or should we also be thinking about qualitative measures? And those aren't necessarily called metrics, but maybe we should be thinking about measures and thinking about both process and outcome measures, as Sandra Gasca Gonzalez talked a little bit about in her presentation. And finally, as we begin to think about this and think about metrics or measurement, I want us to think about what's the purpose of this? And are we doing it to drive change? Are we doing it to better understand the ecosystem? So are we just gathering data? Or are we doing it for differentiation and ranking, sort of like a US News and World Report, the way that hospitals say are ranked? And if we're doing it for ranking, will that actually drive change? Are our metrics, our measurements gonna help us actually catalyze change? Or is there an inherent risk? Might we collect metrics that actually have people think about, actually reject the metric, question the validity, and actually perpetuate structural racism? So again, as you hear our panel, please consider their presentations in the context of our own professions. I think we're all at different stages of this journey. And so I encourage all of you to think about what's your learning edge, institutionally, as a profession, and then looking forward to that robust discussion after our panelists. So right now, I have the great pleasure of introducing our panelists. Again, I want to refer you to their full bios that are available in the link in the chat. And let me go through and introduce them. So we have Sonal Batra. Sonal is an assistant professor in the School of Medicine and Health Sciences at George Washington University. She's also a founding board member of the Beyond Flexner Alliance, and is serving as a PI for the Social Missions Metrics Initiative. Next, we have Mary Clifford. She's a professor of criminal justice studies and interim lead organizer of the Community Anti-Racism Education Care Initiative at St. Cloud State University in St. Cloud, Minnesota. The third panelist is actually a duo, and it is Priya Garg, who's the Associate Dean for Medical Education at Boston University, and also Maria Soto Green, who is currently the Executive Vice Dean at Rutgers, New Jersey Medical School. And both Priya and Maria are co-chairs of the Association for American Medical Colleges Medical Education Senior Leader Anti-Racism Task Force. So with that, and each of them will speak for 8 to 10 minutes, and then we'll have a discussion after that. So with that, I'd like to invite Sonal to please speak.
Hello, everyone. Thank you so much again for having me. It's such an honor to be here, and I really appreciated hearing from that first panel. I'm going to be spending the next 8 to 10 minutes or so discussing the Social Mission and Metrics Initiative, which is a project of the Beyond Flexner Alliance, an organization really aiming to promote social mission in health professions through advocacy, research, convening, and community building. And I'll start with defining social mission and its overlap with anti-racism. They are certainly not the same thing. And I think echoing Rick's comments at the beginning, there are similarities, but it's important to be clear on what exactly we're speaking about. So let's go to the next slide. The social mission, as defined by the Beyond Flexner Alliance, is the contribution of a health professions school, so very much focused on education and educational institutions, in its mission programs and the performance of its graduates, faculty, and leadership in advancing health equity and addressing the health disparities of the society in which it exists. So very much focused on what schools are doing or educational institutions are doing to promote health equity. Next slide, please. Anti-racism, and of course, there are many definitions out there for this term and for racism, but just looking at a simple definition is a system in which we create policies, practices, and procedures to promote racial equity, as opposed to racism, which is essentially the opposite, a system that continues to perpetuate race-based inequities. Next slide. So I put together this graphic, and it's pretty oversimplified in some ways, and there's probably a lot more bi-directional relationships and other things that one could add on here. But thinking about the two, anti-racism is very squarely focused on racial equity. Social mission is on health equity. And while they're separate in this Venn diagram, in reality, those things are very much interrelated. You cannot have health equity without racial equity. Conversely, health equity is a portion of racial equity, but health is not the only sector in which we see the impact of racism. But they are both related to upending current social constructions of power that have plugged one group as being better than another and given more power to certain groups over at the expense of others. And they are both focused on structural change more so than interpersonal change, and thinking about resetting priorities. So not just learning new things or doing new things, but changing the things that we are currently doing and the ways in which we currently do them. And I think that was really echoed in the funders panel earlier. Next slide, please. So just a brief background of the Social Mission Metrics Initiative. This has been a project that's been funded by the Robert Wood Johnson Foundation, also with some funding from HRSA over the years. We started with thinking about how do we measure social mission, and we looked at what else was already out there to measure similar concepts in social accountability. We decided to create a survey that was targeted at school leaders, so typically the deans of a school, and we started with medical, dental, and nursing schools. We went through a several year process of testing and refining this survey. And then in 2019, we launched a national self-assessment campaign, which I'll speak more about in a moment. Since then, we've done some further analysis of these measures, looked at how they're associated with health equity outcomes, looked at the impact of schools in participating in this type of process, and figured out some strategic planning for the future. Next slide, please. So just some examples of the type of questions that are in here. We have 79 actually scored questions in the current survey. And each of those are essentially measures that are then combined into certain activity areas, which I'll share with you in a moment. But I pulled out a few that are most directly related to today's topic. You can classify measures in many different ways. But I pulled out here some that can fit into the categories of process, structure, and outcomes. Sometimes process and structure are put together. Again, you can think about these in other ways as well. But one of the process measures was, has your program reviewed curricular content for evidence of racism within the past 5 years? And then in the actual document, there was a number of examples of how that might have been done. Are there specific mentions of racism, anti-racism, bias? There's also a number of other terms. I didn't want to overload this here in the school's mission statement or in the strategic plan. And then one of the educational outcomes that we looked at, in addition to more common questions around demographics of students, of faculty, and of academic leadership, but we asked for graduation rates by race and ethnicity. We also asked for graduation rates by percentage of students who were first generation to go to college, and a few other factors. Next slide, please. So I mentioned in 2019, we disseminated this survey instrument to schools across the country. We invited all dental and medical schools in the country and a subset of nursing schools, specifically those that had baccalaureate or master's level programs. We're in the middle of working with the Organization for Associate Degree Nursing to advance this to associate's degree nursing programs as well. And about 35% of schools participated. This was a survey, again, targeted towards deans or leaders of schools, and it was pretty comprehensive. You saw some of the questions in our pilot testing. On average, it took somewhere around 6 to 8 hours to complete and involved data collection from a number of different offices. And of course, this was entirely voluntary. So it was a pretty robust response, taking all that into account. Next slide. So this is an example of the type of feedback that schools received if they participated in the survey. So on the right side are 18 different priority areas. These are all areas of functioning that all schools or most schools are involved in. And since this survey in 2019 in our revisions, we've actually reclassified these a little bit and taken some out and are down to 16. But schools got a score in quartiles for each of those areas. In addition to that, they also received an overall score in quartiles, which is not shown here. So it tells you in the area of curriculum in this example, compared to all other participating medical schools, you're in the top quartile, so 4 stars. But in the area of community collaborations, you have 1 star. So it gives schools feedback targeted to looking at what are their strengths, what are their weaknesses, and ideally to help schools think about how can we move forward with this and what are areas that we can continue to focus our attention on. Next slide, please. We are also, with that type of data collection, able to look on the aggregate level at what is happening across the country and what are some differences across school types. And so this example is looking at differences between private schools and public schools. And this includes medical, dental, and nursing schools, all of the schools in our survey. The blue squares you can see are private and the orange circles are public. And the takeaway here is that for about half of the areas, private schools are doing significantly worse than public schools. And we can do similar comparisons across disciplines, across geography, school size. And I think the point here is that these can potentially help identify what are some of the drivers for high performance in social mission. Is it that the funding source is making a difference? And if so, why is that? And hopefully that can continue to inform not just schools themselves, but policymakers and others to think about how can we drive change in educational institutions. Next slide. So we are also able to see how is performance within a school, so performance on these metrics associated with various health equity related workforce outcomes. So we used a few outcomes that we had access to data for and found, for example, that schools that performed well on the social mission metric survey in the area of school mission, so that included kind of governance documents, mission statements, and strategic plan, had higher rates of graduates working in rural practice. And we saw, these are just an example of a few, but we saw many correlations there with performance, looking at those structure and process metrics and what their graduates were going on to do. Next slide. We also did a number of interviews with schools who participated in that 2019 survey to see what did receiving the results, what kind of impact did that have on your school? And this was a bit tricky because schools completed the survey at the end of in the middle of 2019 and got their results at the end of 2019. And then of course, the world blew up in 2020. And so it was all a little bit mixed up with having to deal with COVID. But some of the areas that we thought were interesting was that a lot of schools talked about the need for better data tracking. So for example, that question about graduation rates by race and ethnicity, we had quite a few schools who were not able to get that information, and a number in these qualitative interviews reported that that was the type of thing that they wanted to track going forward, and figuring out which offices within their institutions needed to speak to each other in order to do so. We had examples of schools sharing that feedback report with various stakeholders, in some cases putting it on their website to justify, here's something that we're doing and we're really performing well in this area. But also a school that was in the bottom quartile in most areas, whose leader said they took it to their board of directors to try to advocate for increased resources for certain areas. Again, those feedback reports were entirely confidential. There was no public ranking or rating, so only the school that participated could see their results. So you knew you were in the 4th quartile, for example, but you had no idea who was in the 1st, 2nd, or 3rd. And then, again, thinking about really the key point here, which is driving change, a lot of schools spoke about examples needed for resources for improvement. So the Beyond Flexner Alliance is working on some of these best practices and creating learning collaboratives. I think the example that Dr. Humphreys gave of the Mount Sinai initiative, which actually GW is part of and I have been involved in, of this anti-racism in medical education is an example of a learning collaborative. And I think the Social Mission Metrics initiative gives the opportunity to create sort of targeted collaboratives around certain areas. Next slide. And then just thinking about the impact of health professions culture. So this is a related sort of outcome, but many of you know that the US News and World Report recent rankings for best medical schools added a number of rankings besides, sort of the traditional focus on research dollars and reputation, but looking at diversity, looking at graduates practicing in underserved areas in primary care and in rural areas. And this was really informed by some of the predecessor work of the Social Mission Metrics initiative, sort of ranking medical schools based on their health workforce outcomes. And I think that it speaks to the power of metrics, right? Because having this out there and having a publicly facing rankings really does impact, the types of schools that students might choose. It might impact funding, and schools want to compete and want to be competitive. So while I think that this does create, as Luba pointed out, the potential and certainly increases the potential for people to push back on the measures and to say, well, these aren't the right ones or these aren't the only ones. I think it really does, from what we've seen, create impetus for schools to make change. And I'm going to leave it at that. My next slide is just my contact information, which I think everyone has, and there's some more information about this on the website. Thank you all so much.
Sonal, thank you so much for that excellent presentation. Lots of food for thought. I'd like to turn it over now to Mary.
Mary, you're on mute.
Thank you very much. Thank you again for the invitation and good afternoon to everyone. I'm just really excited to be here because I am happy to share some of the work that we've been doing at St. Cloud State University. Some of you may know that we've been doing this anti-racism education work since 2004 when we built the Community Anti-Racism Education Initiative. The goal of that initiative was to bring some workshop information to community members and to invite conversation around what it means to have an anti-racist understanding. And then from there, we started thinking, how can we intentionally build some frameworks for educators, for people in the classrooms to do this work? And so from that, we've been doing that work for about 10 years now. And from there, I'm happy to announce that we just launched last week the Anti-Racism Institute for Teaching and Research at St. Cloud State University. And of course, the framework that you see in front of me, feel free to advance the slides by one, is a kind of, here's the collection of the people, the collaborative that put this framework together. And a lot of the work that we do is in collaboration because we bring a lot of people with different elements and different strengths together to do this work. Please advance. And you can see this anti-racist praxis slide is an invitation to think about how deep and wide the work really is. I think that when we started doing some of the work originally, we didn't fully understand that the work had so many parts to it, multi-levels, deep and wide. And the idea, of course, you can see in this 4 little quadrants, you can hop on at any segment, but you also have to kind of keep inviting reflection and conversation in each of the sectors. So we'll just start at the top at the 12 o'clock, looking at critical self-reflection. The idea that we have to understand our social position, the idea of where we bring our own understanding and what our own limitations might be, is one of the places we sometimes forget to think through. And so we think about what we teach in the classroom, what the content is, what the curriculum is, et cetera. But we also don't think about where we come into the conversation individually. Thank you for that. And so when you think about how we bring in our own disciplinary understanding, for example, how we bring in our own economic or how our own geographic location may influence our own understanding of the work, It's just really important to think about that critical self-reflection. And so you can see the next quadrant, teaching, research, and learning, is another element of what we've tried to do is focus on the classroom. So we have educators. The center point of the Anti-Racism Institute came out of an anti-racism practicum, and the work within how we teach in the classroom, how we create a classroom environment that is student forward, that's an invitation for students to empower themselves in their own understandings and to bring all aspects of themselves into the classroom. And the idea is it challenges that sage on the stage kind of understanding that sometimes teaching can take on. And it's an invitation to build community, to build a research environment within the classroom, and to invite all of us, including the instructor, to learn from each other. And so the idea of how we teach and how we learn, some of this is identity change. So we need to better understand how we see ourselves, and then how we see, for example, our disciplines, how we see each other in the classroom, and what that might mean for the collective. So then from there, we move into this idea of action. And action, of course, is exactly what it sounds like. We have to move into, where do we put this in play? Sometimes, if you can imagine, moving from the classroom into a research project, or from the classroom into the community, doing community action-oriented research, those kinds of things. But the goal is to apply change. And then, as has been illustrated here, really importantly, how do we do an analysis or an assessment of what that change actually looks like, how we might see it reflected. And then, of course, the idea is, as has been said, that we've got to continue to refine our operations. It's not a one and done. We just have to have an ongoing operation and do an ongoing evaluation, reflection, et cetera. So if you move from the action piece to community building, again, you can see it's not a perfect split in these four components of this quadrant. It's just an opportunity. We've kind of joked a little bit about the primary colors and the use of primary colors. These are things that kindergarteners, we know that racism happens really early. The idea of how you start to see yourself as separate, all of these things happen really early, but it's a very fundamental kind of way of knowing. And so it has to happen in community. It has to be working in collaborations. We do a lot of communities of practice, for example. It's not enough to do a book club. We have to see, what does the book tell us, and then how do we bring the themes from that book into the community to have conversation, and then move us along these other quadrants. Again, how do each of us take the contents from something as simple as a book club, bring it into our own critical self-awareness, think about how we can deepen our own understanding, think about how we can kind of look for our own blind spots, and then, of course, come back around. Other elements of the community building piece that are so important are really, I think, fundamental in terms of how we see each other and how we define community. Because a community, of course, can be a classroom. A community can also be an apartment. You can see how these kind of waves extend out. And from the department, it can be a college or a school. It can be an entire campus. And so when you start thinking about moving the campus into the community in a broader way, what are we doing in terms of understanding what the city might be doing? What is the city council doing? And then how are we reflecting that back into our collaboration between the campus environments or different groups on a campus environment? And then, of course, bringing that out into the community. Some of the things that we did with the Community Anti-Racism Education Initiative early on was develop programs in the community so that we could have a common understanding, common dialogue, common terms. How do we collectively understand these themes and ideas so that we can have a conversation and not talk past each other? So we have a lot of fundamentals that we go through repeatedly, but as you get more informed and have greater learning around anti-racism education, we also know that you need to have, again, this deepening and a better kind of, how do we apply this at a deeper level, at a secondary level, involving more people? For example, one of the things we're doing right now is talking about this notion of community-led initiatives. So we had workshops, we had developed a whole series of things that we could bring out into the community, and we could have the city council go through these workshops. We could create additional community NGOs and other operations to kind of do this work and make sure that there was opportunity to do a lot of educating around anti-racism in the community. But the problem, of course, when you think about community-led, this idea is we're going to tell the community what they need. We're going to create this academic arena of understanding and then take it out and then share it around with a lot of folks. So as we deepen our own understanding about the collective, what does community even mean? The Community Anti-Racism Education Initiative, its first word is community, and the idea of building community around this idea is challenging. And so a community-led initiative has to invite reflection from the community itself. And at St. Cloud right now, we have 4 very underserved community areas. The schools, basic K through 6 schools, are free or reduced lunch qualified at 80 to 90%. And so we have extreme poverty in those areas, but we also have an extreme need for understanding how these policies are going to implement and impact the kind of change that we're looking for in that area. The people who are going to be on the ground, the people who are going to know the most about what is needed in that area are the people in the community who are impacted by this social reality. And so how do we build a relationship from the university into the community that is community-led and driven? How do we have those larger conversations about building a relationship between a university when sometimes the university will go all the way across the country to Singapore, for example, and build programs to bring students from Singapore, but we have students across the street and in our school districts in our own city that don't have access to higher education. And so you can imagine then that at these levels and layers and now these rings, concentric circles go out, and we start thinking about how do departments and disciplines influence our understanding of anti-racism work. You can see, I think, that we really have our work to do in all these quadrants, but it's not just a level of depth. It's also how wide out does that circle go and how do we create those opportunities? So this idea of community building is critical. And you can see, I think also, if you jump in at teaching and learning, you're going to almost always immediately, go back to critical self-reflection perhaps, or you're going to go into community building. It doesn't necessarily have to work in that clockwise direction that you see here. It's just another opportunity for us to kind of take some small pieces and parts, put it into a better, larger context. And then as we think about what that context might provide, think about ways that we can make some change. So this idea is we're taking theory to practice. The entire kind of focus is how do we move from that, what we're learning, into what we need to do in terms of taking action. And other people have said this, I just want to reemphasize the idea that we take action isn't enough. We have to see what kind of impact we're having, right? We have to see how people are served. And then we also have to think about what are we missing. And so all of these kind of metrics that we're talking about today are really invitations to move into a deeper understanding. And we haven't had this. I mean, we've been doing work for 20 years at St. Cloud State. And some people say, wow, you guys are on the cutting edge. But we are still trying to figure out ways to kind of understand better the evaluative pieces, because as you can see, when you have so many different opportunities for doing an evaluation, what exactly do you measure in a quantitative way? Some of this is very qualitative, right? And so the idea of how those relationships are developed and what is really successful in building those relationships, the idea of money and all of those things are factors, but sometimes you can have some really successful programs that don't have the kind of financial leverage that others have. And so what are those essential factors? And so all of these are things that we're going to try to more intentionally address through the Anti-Racism Institute at St. Cloud State. I did ask that Hannah would put that in the chat for you all if you're interested. We're still evolving in our own kind of graphic kind of representation of the work that we do at the web page there. So it's very new. And of course, we're going to be doing some updates. If you want to go back, Hannah, if you can, quick to the full slide, you can see that all 4 quadrants have a part to play. And I think that as we look at the entire ongoing kind of cycle of how we do work, kind of within our own space and place, within our own hearts and minds, and then of course out into the community, in the classroom, bringing community into the classroom, all of those dynamics have an important role. So I'll stop there and we'll kind of leave any kind of questions that you might have for later, but I sure appreciate again the opportunity to be here. Thank you all.
Thank you so much, Mary. And that was excellent. And let's now turn it over to Priya and Maria.
Good afternoon. I'll be kicking off, and I must say that I am equally inspired. So it's wonderful to be here with these amazing colleagues and with all of you this afternoon. I am Maria Soto Green. I'm at Rutgers, New Jersey Medical School, where I serve as Executive Vice Dean. And I'm accompanied today by Priya Garg, who's Associate Dean of Medical Education at the Boston University School of Medicine. And we serve as co-chairs. Today we come to you in that capacity, the Association of American Medical Colleges Medical Education Senior Leader Anti-Racism Task Force. The group came together, and we as senior leaders representing the individuals that report directly to the dean came together in July 2020. And initially there were 10 members to do it, and were tasked with drafting a roadmap for our institutions to address racism in medical education. And we have grown to 17 members representing a diverse group of medical schools in size, location, student body, faculty, and more importantly, readiness to address racism. If I can have the next slide. And this was the title of our first, the roadmap that we created. And the intention of the roadmap was to clearly acknowledge that we as senior leaders condemn the structures of racism that have allowed inequities in medicine and medical education to persist, and to acknowledge the responsibility we have as educational deans to address and eliminate racism from the learning environment and provide action steps to all institutions, as was excellently articulated in the prior session by our funders who are trying to drive change. So I'm moving forward, if I can have the next one. We started with the following question to our 17 senior medical education leaders. And we used Dr. Camera Jones, which you've heard repeatedly cited for her framework, to develop categories for a cause and effect analysis. And you can see them depicted: the systemic, institutional, interpersonal, and internalized. And again, like to echo that our work is, focusing, while it's on all, addressing systemic and institutional. If I could show the next one. And you can see this is what came when we asked the question: what is driving the culture and learning environment of medical education to be racist and inequitable? And if we can start at the tail, not that, and you can see, and we look at the systemic, and it has been, the historical, while we as medical education senior leaders, have traditionally focused on health inequities and the social determinants of health, there's been a lack of recognition of historical factors and the recognition of racism and its impact and its preeminent role, and the inclusiveness of us being able to address this and permeate what has become the impact on our professional and personal lives. So you can see that on the left depicted as these were, the lack of that recognition, the unequal access to education, resources, privilege, the lack of training spots, right, for physicians. And I think these we have come to know all too well. As we move on to the institutional, yes, we do have our accrediting bodies, but we felt the lack of accreditation and certification requirements supporting anti-racism. And you've heard it repeated. The work is early, but the work is needed and action is important. And the lack of the policies themselves that address diversity, and that's what our call to action at every single level, at the educational level, at our research, our funding, and the promotion is who gets to be advanced, and the disproportionate weighting of exam scores and what they mean and how they may impact how the door swings. And obviously, and as we move, particularly the lack of faculty development and the requisite expertise in this anti-racist work. And as you move, towards our fishbone, you can absolutely see the interpersonal activities of which, we've heard a bit about, particularly from the Josiah Macy Foundation, obviously, bias and its absolute training and how it affects everything that we do and who comes in, our microaggressions, as you can see, and really just a general lack of awareness of the impact of the way our structures have been. But this is our interpersonal, and then finally, obviously, culminate with the internalized and individual levels. So I'd like to move to the next slide. So one of the key things, for us in the creation of this particular roadmap was to really begin to discuss our goals in anti-racism and what did we want to do now, and to really move the momentum of the call for action from our students, but to make it that it was our responsibility to change. And that these were areas that needed to, not only important areas that needed to be addressed over time to be able to change. The action steps were divided into 3 categories, are the immediate, as you can see depicted, right, and cultivate race consciousness, the short term, and the long term. And as you look at the short term, examine our institutions, right, and really what is it that really permeates us, not just only in content, our pedagogy, our evaluation, our overall, environment as we look. And then long term, I think that's where we're here today, is the sustainable change and policies that we can have, not only looking inward, but also looking outward, and how we collaborate and how we, again, share in that responsibility and accountability. So I'd like to turn it over to my colleague.
Thank you, Maria. So as Maria said, we were really looking to think about the roadmap in 3 domains, and we wanted to create a sense of urgency. So we began to focus in on our short-term actions. And we thought first about leaders, and this has already been articulated, but the leaders themselves, our colleagues, needed to educate themselves. And then we wanted to move towards the structural changes, what institutions needed to do really to focus in on changing policies and procedures to drive an anti-racist learning environment. And as you can see from the beginning, the group really wanted to think about structured self-assessments to help leaders think about the pervasiveness of racism within medical education programs across the continuum and about the opportunities to change. As a task force, we recognize in order to recommend a self-study, we had to provide institutions with a tool that allowed them to do so. We wanted to drive the change that we wanted to see, and we wanted to provide direction to senior leaders who are less knowledgeable about racism and the structures that really impact medical education, health professions education. Next slide. We can go to the next slide after that. So in terms of metrics, which I think is an important question that Luba started us off with, is after our roadmap received unanimous support from MESL, which includes all of the member medical schools in the US that are LCME accredited, our task force goal was really to call people in rather than calling them out. Many of us in our roles had received report cards that reported our institution's performance in diversity or anti-racism, which we were not a part of and weren't clear about how the data had been provided, and felt that that really dampened our drive to change, our institution's drive to change, because the focus on the report card became the score and how to achieve the score rather than how to create meaningful and sustainable change. So we determined that our tool would be one where we really wanted to focus on driving change across medical schools. Next slide. The scale we decided to utilize was a readiness for change scale. We thought it would allow institutions to acknowledge where they are and where the opportunities are for them to start and for everyone to start. What we heard from our initial task force and members of our community were that many people were early on and many people were later on, And we wanted to be inclusive of everyone. We also, in aggregate, wanted to understand where our community's strengths and areas of opportunity were as a group, because part of this for us was really trying to collaborate and think about how we could work together. And so for us, we wanted to understand where were the pain points where no one was ready for change, and where were the areas where we were doing a much better job and probably needed to have less focus at the moment. Next slide. So we chose to focus on 4 large domains in our tool. The first was thinking about institution and resources, which really focuses on mission alignment towards anti-racism and education, leadership acknowledgement of racism in medical education, faculty recruitment of underrepresented and historically marginalized groups in teaching and administration of our programs, faculty retention, and then actual CQI or quality improvement processes that showed the progress towards a more anti-racist learning environment that were embedded within the institutional processes. We thought about educational programs as another large bucket. So many people think about educational programs as curricula, and that to us was one piece, but also thinking about holistic assessment and evaluation for bias in assessment, faculty development for all of our teachers, trainings about racism, and really inclusive pedagogy overall. We thought about learners and really thought about focusing on anti-racist policies and procedures everywhere learners interact with the school, from admissions to support services, honors, and awards processes. And then finally, the learning environment was its own domain, because for many of our schools, our students are going across many clinical sites, and there are many faculty and staff involved in their learning. There are policies across multiple institutions. And then there's the built environment at all of our schools, and how is that representing anti-racist beliefs. And our major effort has really been to not only think about creating a tool, but linking it with resources. So when an institution identifies their area of growth, how are we able to provide them with the tools so that they can move forward? Next slide. This is an example of our 2.0 version of our tool that's currently in another round of iteration and a work in progress. Our task force right now is broken into 4 working groups, each working on the domains I just described. We're really focusing on examining the language we're using. Is it understandable to a broader community who may not have expertise in racism? Are there enough of the subcategories? Are we touching upon all of the areas we want to and driving that thought process at institutions? Are we linking to the literature and what's known about racism in health professions education? And will our leaders really be able to think deeply about the domain and racism at their institution? We want this to be a guide, so we're working on not only a tool, but also a facilitator guide that allows institutions to think about the resources and the tools associated. And we hope our next steps is to refine the tool, pilot it at our institutions of the members of the task force, and then broadly across the medical education senior leaders at medical schools across the country. Next slide. So we've spent a lot of time actually with a lot of questions within our group and challenges, and I wanted to share those because I think it's a really important part of the journey. And for us, a lot of it has been, where does medical education begin and end? How do we create a tool that has limits when we know that medical education is touched upon by the mission and the governance of the institution, research at the institution, but our expertise in actual domain is medical education itself, and what are those limits? How do we ensure that the domains make sense to everyone and everyone who is at the beginning of the journey and those who are closer to the end? How granular should we get? What's missing? What are we not thinking of? Does the scale make sense to drive change? Is it the right scale to use? Who at the institutions should be using the tool? Who should the data be shared with? And is this a part of accreditation or separate from it? And we hope to work with the larger health profession community to really think about all of these questions as we are hoping to provide an initial tool that hopefully can be revised and drive change in the future. So thank you to everyone for your attention.
Thank you so much, Priya and Maria. And I don't know that I mentioned that I'm also a member of the Anti-Racism Task Force. So I want to begin with a question for all of our panelists. And it's on the subject of generalizability. So we're here now with 17 health professions, educational leaders represented. And I'm wondering from where you sit, what metric might be generalizable and might apply to all 17 health professions represented here? Is there a metric that we should all be collecting? And you know what, I'll make it more broad, not metric necessarily as quantifiable, measure. So is there something that we should all be collecting as we think about driving change?
Stop.
I think the one, if I may start, because I do have the benefit of being at Rutgers Biomedical Health Sciences. So weekly, I have the opportunity to be with the Dean of the School of Nursing, the Dean of the School of Health Professions, the Dean of the School of Pharmacy, as well as my dean serves as both our dean and interim dean at Robert Wood Johnson Medical School, as well as the Dean of School of Dental Medicine. And the big one is the learning environment. So I would say we all, right, come together on, you know, what is it that in our learning environment, right, for our health professional students, and it isn't just around the IPEC principles, right, which is, you know, learn with, about, and from each other, but particularly those are the fundamentals that we want to espouse, but really bias in the learning environment. How do we create, and I think we had a touch tone from our funders, is that, you know, yes, we're inviting individuals in our inclusive, equity-minded strategies, but are we really turning those into actionable steps through our policies, practices, and through us, right? As the individuals who are tasked with educating our learners.
Thank you, Maria. So you really focused on bias in the learning environment. Other panelists?
I think that, I mean, this is like, you know, going back 50 or 100 years in time, but we still haven't really achieved, I mean, just compositional diversity, right? And not just at the student level, but at the faculty, the leadership levels. And, you know, we know obviously that is insufficient, that, you know, having sort of people in your building does not make you an anti-racist institution, and is certainly not enough. But you can't really get there if you don't have that, right? And so, and we know across professions, we're really far away from having sort of parity with the population and population served in terms of the providers and the health practitioners. And so I feel like that's a really basic one. And on the one hand, you know, by and large, that is being collected. But, you know, I think that it needs to be intertwined with the other measures that we're talking about, because obviously, if you want people to get through the door, you have to change policies, impact, you know, not just healthcare, but also other systems that prevent people from being able to have those opportunities to get to the door, and then support them when they're in the door and help promote that. And so it's all, of course, intertwined, but at that very basic level, I mean, that's an, I think, important one still.
And Sonal, can I just ask a follow-up question, which is, I know that you have been really involved in looking at accreditation standards across the health professions. And as it relates to compositional diversity, it's a real floor kind of metric.
Yeah.
Is that a part of all health professions education accreditors?
No, and you see variability. So we had a paper out that looked at 9 different accreditors and their standards, and included medical dental nursing, but also pharmacy and PA standards. And it's not in all the accreditors. And we also looked not just at student diversity, but faculty and leadership diversity standards, and that's even less commonly represented. The Future of Nursing report that came out recently, I think, cited that those findings because the nursing accreditors didn't have, you know, student diversity really represented at all. And while it wasn't one of the initial like sort of categories that we searched for, we did do a search across all the 9 accreditation standards we looked for the term racism, anti-racism, anything associated with racism, and it was present in 0 of the accreditation standards.
Thank you, Sonal. Mary.
Yeah, I just wanted to kind of offer a few things too. I think one of the things that we see in the higher education outside of the conversations in the medical industry, perhaps, but we see such diverse ranges of acknowledgement and acceptance of this as a conversation for interrupting racism, even on the campus across different colleges or schools, right? And so departments, people in departments, we see just a variety of different I guess, commitments to the idea that this is an intervention required. We saw efforts in the early 80s to bring in, 30 faculty, diverse faculty to meet student requests for this diversity. And we did not see the kind of retention of faculty. So the minute you identify one problem, it slips into another kind of problem in terms of retention or intensive recruiting, and then maintaining a kind of environment that will keep people where we're hoping to see that change actually really come to bear some fruit, right? And so I think some of the challenges that we have are, the deep and wide components of this, right? In terms of, the qualitative elements are essential to the numbers and the ongoing reflection. I think traditionally education has been, what do we need to know? And then we're done, kind of, right? But it's just not that model at all. It's an ongoing evolutionary kind of review of content in various sectors, and then how do we intersect, and then how do we realize kind of what impact change here is going to impact the kind of connection there, and then we'll see other changes in other places. And so it's an integrated kind of dynamic, and I think that's a really hard analysis or evaluative tool that is going to be required to help us understand the breadth and depth of that.
Thank you so much, Mary.
Luba,
Priya, do you have something?
Yeah, I just wanted to add to follow up with Mary. I think the other thing we think about in that integrated approach is that resources are really important when you're thinking about how you're going to move this change forward and sustain it. And I think the approach that many schools have taken is to have the one designated leader of anti-racist efforts who is taking on a very complex problem, as we know. And that idea of all these places that are being touched by racism really requires a larger amount of sustainable resources going towards, different groups that are interacting in different domains to really think about how to make institutional change rather than the curricular person, the person who's in the dean's office, the person who's in the diversity and inclusion office, and how do we really bring it together so that we're thinking about this in a much more structural way.
Thank you for that. Marcus, as you get ready to have a look in the chat, can I just ask one quick question? I'm really struck by Mary talking a lot about invitation, Priya talking about calling in, and the fact that two of the metric tools that we used actually are around self-assessment. And as we know in the self-assessment literature, sometimes it's the people who are least competent, who are least able to self-assess. And just, if I could have one of you, before I turn it over to Marcus, just address this issue, which is, I love the idea of self-assessment and really, as a tool to engage and drive change. But what do we do if someone just doesn't know what they don't know?
Just talk a little bit about the leadership team where we are. The leadership team and community members come into the university and ask us to be accountable, right? And so part of the collaborative is seeing the blind spots that we don't see for ourselves. Part of the reason to do collaborative is to invite conversation about what it is we don't see. Even after doing this work, could we have said it better? Could we have done it better? How do we do those kind of personal changes and modifications, and then of course bring that back to other larger conversations as the concentric circles go out. So that's just, again, one of the, it is a bigger issue than just a one-time deal, and I think we constantly kind of want to, okay, how do we fix it moving on? But it's how do we fix it now, and then how's the world around us changing, so how do we adapt to the change? All those things are important for moving forward.
Thank you. I'd like to ask for more, but I'm worried about our time. So Marcus, do we have something from the chat?
Yeah, I'm going to try and combine two questions here. And I think it really is dovetailing off of this conversation, a point that was made in the previous panel about accountability, not just of schools, but the enforcers, if you will, or the gatekeepers, or the funding of the accreditors. And this one question came in about the AAMC specifically, but I'm going to broaden it out. And another question about who defines what harm is in a pluralist society. So the question really is, you know, as people who are trying to enforce these metrics, my interpretation is, you know, we're trying to talk about the need for diversity, equity, and belonging, but sometimes the gatekeepers and those in power are not diverse. So we're trying to hold others accountable when we're not holding ourselves accountable. So I guess the question then becomes of how do we walk that walk and hold ourselves accountable in how we are, you know, setting this work forward. I know in nursing, for example, we're constantly talking about, you know, DEIB, but the people at the top aren't diverse. So it's hard to kind of take what they say when they're not holding themselves to the same standard. So would welcome comments in that regard.
I think it takes bold leadership. And you're right, because that's the challenge that we have with many of our bodies, right? From, you know, accreditation to, you know, our organizations that we belong to and our task force. We've had, you know, these very open, honest, direct conversations that it's our practices that we constantly are deciding what is it, depending on the color of my skin, that I'm more capable of doing. And you can see the door doesn't swing, right? In the direction that it needs to be able to advance it. Why is it in the CEO of senior educators, and for example, that we don't see more dimensions of diversity? And equally, it's those individuals, right, that we then are not, from the time when the pathway programs are important, but from that time, right, of coming into medical schools and going into residency, that the door doesn't swing, you know, to really promote and advocate and sponsor you to become a section chief, a division, you know, division chief, a chair. And so we need to really look inwardly. And you're right, I think I love the funders. A couple of them really did a touchstone of saying, before we go out there, and we know we're out there, let's look at ourselves inside and let's decide what it is that we need to do institutionally to change the paradigm. Because if they were to do it, I think that they would help the rest of the nation to say, look, these were the measures that we did, even though they're different. And therefore, there might be other adopters who were much more cautious in casting their path. And I saw Mary nodding, so Mary, you.
Yeah, I just wanted to add, I mean, we had bold leadership when we started the Community Anti-Racism, 2004, and then we had bold leadership again at the university level here at St. Cloud State, with the president saying, let's get this institute off the ground and figure out how we're going to fund it later. And I love the comment around that, because we've had other institutions that have not had the kind of support that we've seen from the leadership, that simply they have not sustained over the time, and we've been able to sustain because of that bold leadership piece. And then, of course, trying to be innovative with funding and make that funding last. But I just can't say enough about that leadership piece. I agree completely.
Marcus?
Oh.
Shall we close?
I think so, because we're a little over time.
Yeah. Thank you so much to all of our panelists. Marcus, thank you to you. And with that, I'd like to turn it over to Tanya Smith-Bryce and Rick Baker to close us out.
Wow, this both of these panel discussions were absolutely amazing. I want to thank all of you for the wonderful discussions around funders and what they can do to help with creating an anti-racist space, but also how do we develop metrics that we can use across all of our disciplines to measure where we are in this process. Many of you mentioned multiple times that this is a journey, and it is truly a journey that we're on. There is not a space that we can go to and say we're there. This is an ongoing process, and it's one that requires endurance and perseverance and integrity as we move into these spaces. There's no one answer. There's not one way of doing this. I think we've got to find opportunities to continue to have sessions like this or opportunities like this to grow together, to communicate with each other, to learn from each other as we move across our various spaces. That we have a lot to learn across professions, across our institutions, and across the various sectors that engage health. These workshop sessions that we've had over the past few months have just scratched the surface of what we hope will be a much longer ongoing process that will involve actions and perspectives from all of our stakeholders, our accreditors, our academic leaders, our funders, and students, scholars, and others, as we work together to dismantle institutional structures that perpetuate these discriminatory treatments, unfair policies, or biased practices based on race. And to consider how we might use these metrics for measuring progress towards stronger anti-racist structures in our institutions across this nation. I am just honored to have had this opportunity to chair this work group that has led us to this caliber of workshops. And Rick, do you have any closing remarks that you want to add to this? Rick Baker.
Rick, we can't hear you.
Rick, we can't hear you.
What I said was just wonderful too. No, what you said, I think you said it all, Tanya. Again, I too am privileged and honored to be, with our planning committee, on this great journey, and each and every one of the panelists that we get to share, the journey with. So no, this has been wonderful. This has been a wonderful experience, and as you said, hopefully this is just the beginning of that journey.
Absolutely.
So,
I want to give a shout out to each of our planning committee members. I know that many are here. Some were not able to be here in person, but I think I saw Vineet Aurora, Dr. Aurora, who is Associate Chief Medical Officer of Clinical Learning Environment at the University of Chicago. Dr. Sherilyn Black, who is an Assistant Professor of Practice and Medical Education and the Associate Vice Provost for Faculty Advancement at Duke University. Dr. Hadia Green Guerrero, who is with the American Physical Therapy Association and also with a faculty appointment at Drexel University. Our very own, very proud Marcus Henderson, who is a doctoral student of nursing at Johns Hopkins University School of Nursing, as well as leading the world in solving all of our world problems. We're looking to you, Marcus, to do that. Dr. Limietta McNeely, who is the Chief Staff Officer at the Speech Language Pathology American Speech Language Hearing Association. And thank you, Lemmy, for your leadership. Dr. Lynn Holden, who's Professor of Emergency Medicine at Albert Einstein College of Medicine. Dr. Nadine Karambuks, who is Dean at Tufts University School of Dental Medicine. And Dr. Ryan J. Pettaway, who is an Assistant Professor of Community Health and Health Promotion at the Oregon Health Sciences University, Portland State University School of Public Health. Thank you all so very much for your work. And also Patricia Cuff and Hannah Goodtree. We could not do this without you all. Thank you so very much. And we will end this session with 1 minute that you can get back for yourself. Thank you so much for all who participated. Thank you. Bye-bye.